All right, folks, we're going to talk about advancing health equity and how you can be innovative with your strategies based off of data. So my name is Smith-Elion. I'm a VP of product here at Arcadia, and I'm excited to talk to you about this topic that has evolved rapidly over the last couple of years, and some of the successes that we've had working with our customers to be able to target health equity, social needs based off of a data-driven strategy. So as we think about it, health equity and social needs are just another dimension of risk. They're just another facet of the patient that you need to consider as you target those patients for specific interventions. With all this, you need to integrate health equity documentation, screeners, capture that information as part of your improvement strategy with value-based care. And then thinking about specific intervention types that help address those predicted social need values and really address the patient where they are. So how do we go about doing this? Well, in the current state, we focus a lot on getting the patient into the PCP visit, on the annual wellness visit. We don't really consider their social needs or their blockers, their barriers to care. So what ends up happening is that this patient, Evelyn in this virtual example, and it's an AI picture, not an actual patient, but Evelyn can't afford food. She is struggling. Economic factors today, like I don't know what the cost of eggs is by where you are, but it's about $12 for a dozen. So there's a lot of pressures right now that are increasing, that are putting a lot of our served populations at risk for dietary needs, for food, for transportation. Evelyn here, she can't find a way to the PCP. Maybe she doesn't know who her PCP is. And she doesn't have transportation to get there. And because of this, she feels alone. She feels isolated. So any kind of outreach, an automated text message, that's not going to be sufficient. You need to understand these patients in a much richer way. So how do we go about doing that? And what are the interventions that we need to move towards? Well, it's the point of value-based care to enable whole person treatment of the patient. Social needs are just part of that. It's not just about gaps in risk capture. It's not just about gaps in some quality measurement. It's the whole patient that we need to address. So we need to think about transportation barriers. We need to think about food access. We need to think about isolation and those needs as much as we think about medication adherence, as much as we think about risk gap closure, as much as we think about those care gaps. So how do we get there? So the path to addressing these needs is supercharged by data, by thinking about the information that you have captured about the patient, about the person, pushing that into your data architecture, your infrastructure, normalizing it so that you have a common understanding of those needs across your population, and then marrying that to an understanding of a probabilistic need. So with your observed need, this is where the patient's filling out a prepare form, where you've had your care manager or care coordinator talk to the patient and recorded the fact that they have a social need. But that's not enough. You need to understand what are the predicted needs as well. One of the biggest challenges today in understanding your health equity needs in your population is poorly executed documentation. This is incredibly prevalent across the country right now. And it's not just about running a prepare form or a summarized prepare form, but is that prepare form being administered by front of office staff? Is it being administered by a nurse? Is it being administered by a doctor? Each of those personas will drive a different capture rate of that information based off of how much the patient trusts the person on the other side. You can understand that through analytics, right? You can understand that through looking at the data and seeing who ran those prepare forms, who ran those assessments, and marrying that again to probabilistic need. If you think that in a given geography, in a given zip code, that there should be a high transportation need because there's a healthcare desert there, and you don't see that in the data, in the observed data, you have an education problem. You have a problem with how you're administering that prepare form, that assessment. So it's important to think about not only normalizing and capturing the information about your population, but marrying that up to the predicted need. So how we do this is we're taking that information in, we're normalizing it to FHIR, and using the Gravity Project standard for health equity to be able to get to 17 different social need domains, and looking at both the observed data, the capture data, as well as predicted data around this population. This enables us to light up a number of different use cases, a number of different endpoints, whether that's more targeted outreach, more finessed outreach, looking at how we can surface this data more meaningfully to the providers, to the care managers, so that you're not just looking at the data that you captured in one specific form, but understanding over the longitudinal record of the patient, of the person, what is true, what actually happened, and how that marries up to what should be happening for that given patient. This also allows us to light up the new HEDIS measures, the HRSA measure, in a more meaningful way. So it's not, today it's a display measure, but you need to start understanding what your real capture rate is there. And that's just administering the form, right? That's not actually looking at the underlying data. That will be the next phase as we think about the needs here. And then lastly, there's additional suspecting probabilistic algorithms that you can layer on top of this to really get at the analytics of health equity, to understand those trends in your population and target providers, target practices with education. We partner with a couple of different vendors to be able to determine the burden in your population, whether that's health literacy needs, food insecurity, looking at a probabilistic approach to health equity, and again, marrying that up to the observed data. For one customer, we've been able to look at the needs at scale over about 1 million different patients. And off of that, we're driving very targeted interventions, understanding that if a population has a cell phone issue where they're not necessarily having access to digital information, to text messages, that obviously changes your outreach strategy, right? That drives you to more high cost outreach, whether that's a phone call or a snail mail. But that ROI is justified based off of the probability of the patient answering that, right? Ultimately, you're still driving at engagement, at consumption of healthcare, of getting the patient into the PCP's office. It's not really any different than the way we've been executing VBC traditionally, but this gives you an added layer of finesse, of understanding of your population to really hit at those folks that are not being met, their needs aren't being met today. So in closing, I just want to really encourage you all to think about how you're managing your health equity data today, how you can look at both your observed data and supercharge that with probabilistic data, with predicted data, and really drive at more targeted interventions instead of just the kind of brute force approach that we typically leverage in value-based care today. Thank you, everybody. Feel free to stop by with any questions.